So you've heard some of the medical aspects and the clinical aspects of violence and its impact on healthcare, and now we have the policymakers. So the director and moderator for this panel, Judge Overstreet, Dr. Cooper, come on down. And Senator Pulliam, would you want us to have a seat down there for you, or?
Well, good morning. We're going to get a sort of a rolling start. I want to thank the NMA. My name is Maurice Overstreet. I'm president of the Auxiliary to the National Medical Association. So let's give a little shout out to the Auxiliary to the National Medical Association. We like to say that we're more than just a strategic partner. I know that we have several former presidents of the Auxiliary to the National Medical Association. So I'll ask them to either raise their hands or stand first. I see Dr. Beverly Anderson. I see Ms. Belva Clark. And I know Ms. Walton. Secondly, just members of the Auxiliary to the National Medical Association, just raise your hands. Several members here supporting the National Medical Association. We have two panelists for you today, and they're just very entertaining speakers. I'm happy to moderate this section of it. We're going to merge policy with violence. We have Dr. Cooper, and we have Senator Nathan-Pulliam, and we're going to talk about how you can merge medical and legislative arenas to address the violence that we have here in America. Now, our first panelist is going to be Dr. Cooper. Now, this is a very, very interesting journey that he has and a story that he has to tell. He's associate professor of surgery at the University of Maryland Medical Center. I'm not going to go through his entire bio because I'd be here all morning, but he created a program, and it is a testament to how one person's experience can lead to medical policies that attempt to change. And he has a very, very interesting program called Violence Intervention Program at the Shock Trauma Unit at the University of Maryland Medical Center. And it's one of the first in the nation in terms of putting anti-violence policies directly into the to the hospital. He's going to focus on how policies, medical policies, lead to prevention. Dr. Cooper.
Thank you very much, Judge Overstreet. And good morning to everyone. Thank you for having me. I'm very honored to be on a panel with Senator Pulliam here, a very good friend and someone whom I respect very, very much. So I'm going to talk to you a little bit this morning, first of all, about just the where violence is, and you've seen some slides already that give you an idea of just how pervasive it is. So I'll be very brief on that. And then I'm going to talk to you about two things that I think that if instituted could have an impact on violence, two policy processes, for lack of a better term. One is hospital violence violence intervention program, and then something's a new, just coming on board actually next month is something called a prevention specialist. So the problem you can see here, it is a 50,000 patients a year who die. It is the leading cause of death in the age group 15 to 24. It is the leading cause of death among leading cause of age 15 to 24, and second leading cause of death of African American males ages 15 to 34. The leading cause of death of our young folks in our communities. that's the sort of figure I would expect to see if we were someplace in the Middle East or where there's a war going on. Not the kind of data I would expect to have in our country, and that is where the data is. 80% are killed by firearms, and 34% of them are victims of violence returned to our nation's trauma center. And now that last figure, again, I think is particularly concerning to us. 30 to 60% of all the patients that we see at our nation's trauma center will come back to that trauma center. And when they come back the next time, they don't come back because of a car crash or a fall. They come back because, again, of another violence injuries. And when they come back, their chance of dying is higher. There are multiple papers, lots of data has been published to document that. There was an article written, it came out of New York in 1912, saying that patients who present back to our nation's trauma center with other violent injuries are 10 times higher to die, 10 times more likely to die. Now, whether somewhat inconclusive or the thing about the paper was they couldn't say why. They can sort of conclude that it was some sort of physiological immunocompetence that the patients encountered because of their trauma. Well, these are young individuals, so that's not likely, of course. It's more likely it's something about the social makeup of the community or something that patients doing that's resulting in them being more at risk. But again, that's data in multiple papers saying that when they come back to the nation's trauma, they can die, which says that we have an opportunity when they present to our nation's trauma center to save their life. Some would even say, perhaps about obligation. So this is a rather busy slide, and I apologize for that. But each one of those, there's just data from 2000 to 2010, and this data from one hospital, and if you could focus on just the yellow bars there, what it says is that the yellow bars are gunshot wounds, the green are stab wounds, the blue are assault and blunt trauma, the purple are MVCs, and the red are pedestrian strokes. And on the axis is the axis showing that is their likelihood of dying. And what's remarkable about this is that of all the diagnoses that lead to death, the most likely reason for dying was gunshot wounds. The ped strokes, the MVCs, the assaults. Every year, you were much more likely to die at this trauma center because of a gunshot wound and all those other things. So, given all that data, given the fact that when they come back, they're more likely to die. The question is what can we do to keep our young folks from dying? What are the things that we can do that once they come to our hospital? What can we as physicians do to impact that high death rate? How can we do keep coming back to our nation's trauma center? And one of the things that has been around since the late 1980s, or late 1990s, is our hospital-based violence intervention programs. These are programs that are geared towards using or making use of a teachable moment. That is, when that patient comes in with that gunshot wound, that stab wound, abdomen and pelvis ahead, when their families are at the bedside, for the first time, they may have slowed down enough to ask about what their lifestyle. Maybe that's an opportunity to take advantage and ask the question about what can they do different. What are the risk factors that put them at risk, and what can we do and they do to keep them coming back to nation's trauma centers. They are geared around assessing safety and retaliation risks. There's individual and group clamping. There's group support, legal support. We look towards getting it for those who have mental health issues, giving them behavioral health support, getting them into job training for those who don't have their GED or their diploma, getting them education, getting them into any sort of skill training that is going to be able to move them forward. And again, for those who don't have jobs, getting them into jobs, because there's lots of data out there, as well, that the things that put our nation's children at risk for being victims of violence are that lack of jobs, as lack of education, being in violent and dangerous neighborhoods. So the hospital-based programs are geared towards trying to address those issues while those patients are sitting in our nation's trauma centers. This is just some data. Earlier, I think one of the participants in the audience mentioned the Prescription for Hope, which is a hospital-based violence intervention program in Indianapolis. This is some of their data. This is data from 2009, 2011. I apologize, you may not be able to see some of the data there. But suffice it to say that when they began this program in 2009, their violence intervention rate was approximately 25%. They were able to, in 2011, in the third year of their program, they have reduced their violence intervention down to 1.3%. Again, just by instituting the kinds of intervention that we talked about in the previous slide. This is a study that was done at the Shock Trauma Center in Baltimore that was published in 2006. And if you look at these were 100 patients in the study. It was a randomized prospective study, where half the patients were put into a violence intervention program, and the other half were not. They were all individuals who had been victims of violence once before. These were not patients who had been injured. It was the first time injured, where you may have said, well, they were at the wrong place, wrong time. These were all patients who had been injured once before, who had come back to our trauma center with a second injury, who we went to the bedside and said, look, we have a program in our hospital that's geared towards trying to help you move forward. If you don't have a job, we're going to help you get a job. If you don't have a GED or a diploma, we're going to help you do that. If you do, if we have a substance abuse problem, we'll get you substance abuse problem. Really geared towards meeting those patients where they are and trying to move them forward. So this study, this particular aspect of the study, this is the non-intervention group over here, and this is the prevention program over here. And if you look at ever arrested for violent crimes, convicted and convicted for a violent crime, and if you look at the risk ratio over here, you can see that the intervention group for ever arrested had really no significant effect on them. I.e., these were kids growing up in inner city, and they do what kids do. Kids loiter around. Kids do things like smoke marijuana, and so they did get rearrested for some of those things. But if you look at ever arrested for violent crimes, the folks who were in the program were 3.2 times less likely to be arrested for a violent crime. If you say convicted for any crime, 2.3 times less likely to be convicted of a violent crime, and looked at convicted for any crime, and looked at convicted for a violent crime, they were 4.4 times less likely to be convicted of a violent crime. So the purpose of the program we started was to keep folks from coming back from the hospital with violent injury. But you can see also what it impacted. It impacted criminal behaviors as well. We weren't sure that would be the case when we started the program, but we thought so, and this data confirmed that. The real goal of the study was to see if we could prevent our patients from coming back to the hospital with violent injury, as I said. And if you look at the intervention group here and another intervention group, you can see that of the folks who returned to our hospital, there were 6 patients. There were 6% or 3 patients who returned to our hospital because of violent injuries in the non-intervention group, and 16 patients who returned to our hospital in the non-intervention group. So a significant decrease in the return of patients who were randomized to the intervention program. And not surprisingly, the cost was significant as well. This was studies on when cost of hospitalization was much lower than it is now. But again, the difference in the cost between the intervention group and the non-intervention group was significant. So this is just one of many studies that have been subsequently published showing this is the only randomized prospective study that have shown it, but there have been case comparison studies showing, like the one that's Prescription for Hope that I showed you earlier, showing the same thing. That is that hospital-based violence intervention programs is an effective means of reducing violent-related trauma. Therefore, one of the policy changes that I've been talking about and advocating for a while is that if you look at every every hospital in the country, because if you're tax exempt, are required to have a community needs assessment, and most of those community assessments, they occur every 3 years. And interestingly enough, very few of those needs assessments, even in our nation's hospital where trauma or violence is pervasive, have violence prevention as one of their things. They talk about things, important things like reducing hypertension, reducing blood pressure, reducing glucose, reducing diabetes. Those are all very important things. But if you are a hospital in our nation, cities where our young people are dying, the question I would have is why not have violence prevention be one of those things that you put as your hospital assessment, as your goal for those 3 years. So my policy suggestion would be trauma centers in which greater than 15% of their patients are victims of violence should have a hospital-based violence intervention program. Because again, the growing body of data says that these interventions are able to save lives. Now, for those of you who are administrators, and I'm one of those, I'm a CMO, are saying to me, well, how am I going to pay for that? I'm already I always don't have enough funds for what I'm doing right now, and we understand that. So one of the things that we did was the cornerstone of the programs are our violence prevention specialists. These are young men and women who meet our patients at the bedside. They administer the survey that gets an idea of what their risk factors are in terms of looking to ask questions about their education, where they live, et cetera. And they follow these patients, we follow these patients, but these prevention specialists from a hospital to a neighborhood, a hospital to rehab, a hospital to jail, wherever they are. They are the cornerstone of the folks who are doing most of the work, overseen usually by intervention nurse or our social worker. So that being the case, we went to the National Deform Claims Committee. This is a national committee that looks at non-institutional individuals, and they decide what we can bill for, what our payer sources in the country can bill for non-institutional folks. So in order for us to have our prevention specialists be paid for the work we do, we had to first have them be assigned a taxonomy code. So we went to them and we asked that question. Here is a group of people who does do this work. Can we get them assigned? And their first answer was no. There's no model for this group, USNU. We don't know how to assign you a code, so it's no. So we went back again and said, well, here's what they do. Here is how they compare to folks like community health workers who do have a taxonomy code. And this is why that you should give them a code. They took 8 months, but in January of this year, they came back and says, okay, we will assign you a code, but you will be assigned a code as prevention specialists, not violence prevention specialists. So now we have them sign a taxonomy code. Now the question would be, can we get our payers to pay for the work that they do? And that's going to be a challenge. They become official in July of this year, and we're going to be talking to organizations like you, the American Public Health Association, et cetera, to ask the question: how can we get for our payers? How can we get for other and payers in terms of the Medicaid, Medicare, and private payer sources, third-party payer sources, to see can we have the work that they do be paid for? Because we have data that says the work that they do does save lives. I will stop there. Thank you very much.
Thank you, Dr. Cooper. See, we're not going to give back time. We're going to try to finish on time. You see, Dr. Mitchell let the first guy from Houston, Texas, just run him up. Now, the second guy from Houston, she wants to manhandle me on the time, okay? But we're going to try to finish on time. So thank you so very much, Dr. Cooper, for that presentation. We're going to allow some period of time for question and answers to Dr. Cooper and Senator Nathan-Pulliam. But our next speaker, the Honorable Shirley Nathan-Pulliam, is a very distinguished legislator, serving in her 19th year in the Maryland General Assembly.
22.
Oh, 22. All right. 22. Time flies, doesn't it? But not only is she a distinguished legislator, she's an RN, so she is actually a health care provider. She's the owner, president, and CEO of multiple healthcare companies. She's the first Caribbean-born person and the first African Caribbean registered nurse elected to the Maryland General Assembly in its more than 380 years of existence. I'm looking forward to your comments and the discussions. Senator Nathan-Pulliam.
Good morning. I bring you greetings on behalf of the Maryland General Assembly. It's a pleasure to be with you this morning. I do not have a PowerPoint, and it's because I'm in the middle of the legislative session. I'm working early in the morning to late at night. I was voting until 8 o'clock last night. By the time I got home and got in bed, it was very late. So it was no way all week. That's the way it's been for 90 days. And so we still have six more weeks to go of numerous pieces of legislation. And so I'll just talk with you about health, about violence. But in listening to Dr. Cooper's presentation, Dr. Cooper, we need to talk. And I'll tell you the reason why we need to talk, because in my take-home points, I'm going to highlight what each and every one of you need to do as it relates to being in touch with your legislators and sharing the kind of information. Because right now I'm listening, a piece of legislation is going on in my mind. How can we begin to bring the hospitals and the payers to the table to begin to deal with the hospital-based violence intervention that you just talked about? So during my entire career in office, healthcare issues have been one of my greatest passion. And of course, I have Dr. Donna Christensen, Congresswoman, who has played a great deal. She has been a mentor. She's been an extraordinary person as it dealt with the health disparities in Congress. And of course, at the far end, of the table is Dr. George Benjamin, who was once the health secretary for the state of Maryland, who in his role as APHA, we've had numerous conversations. And so let me just go on and say that as a registered nurse, and you've just heard that I'm one of the only African-American registered nurses in the General Assembly, but during this past legislative session, we now have 3 medical doctors, 1 Caucasian, 1 Asian, and 1 African-American. So we're doing a little bit better. And we have 3 nurses, 2 in the Senate, 1 Republican, 1 Democrat, and in the House, there's 1 nurse lawyer in the House. And so at least we have somebody to can listen to some of the issues, because what you fail to realize is that we make decisions that impact each and every one of your health. And if you don't have people who understand healthcare, they're making decisions that impact you. So you have a responsibility to educate. And I will make sure that's in my theme as I go through. Health disparities, as I say, has been my focus, and while I was in the House, I chaired a subcommittee on minority health disparities. In the Senate, I'm in a committee, it's called EHE, Education, Health, and the Environment, and everything else. Alcohol, I never learned so much more about alcohol. Alcohol, ethics, and election laws. And so I'm not on a committee that deals with all the violent issues, but we all deal with them every day. During my last election, I now represent Baltimore County 75% and Baltimore City 25%. Of the 25% in Baltimore City, it's working in 95% of the time. Okay, my district includes part of where Freddie Gray lived. Okay, some parts of the city most impacted by the riot during this last time. So I do understand the riots and the issues of violence. And I know that maybe 60% of my constituents end up at the University of Maryland with Dr. Cooper. That's where, because almost daily there are shootings. And some of them, and of course I've gone to the vigils, I've stood with the families at a corner, sometimes afraid even to stand there because you don't know if they'll come back and somebody will come back and shoot you. But the last one I stood, it was a mother who was a teacher in the Baltimore City Public Schools. Her son was gunned down right in front of her house. Okay, I had to stand there with her, holding a candle, the pain, just to experience what that woman must go through. And so that's replicated over and over throughout our city and throughout our country. Last year, just before Freddie Gray issue, I started a social determinants of health group. We broke up into 4 different subgroups. One of them is chaired by Dr. Carnell that you just heard. It's the Health and Human Services. And in the Health and Human Services, you deal with mental illness and, of course, includes violence. And so we have 4 subcommittees. One deal with workforce development. The other one is in job creation, one in housing, one in citizen unrest, and criminal justice. The World Health Organization defines social determinants of health. That social determinants of health are the conditions that people are born, grow, and live and age under certain conditions. And the wildest sets of forces and systems shaping the condition of daily life. These forces, systems includes economic policies, system and development agenda, social norms, social policies, and political systems. So under there, in my little district, there's high unemployment, high amount of boarded up houses, high incarceration, high violence, and I can underscore that, okay, homelessness, poor schools that are poorly equipped, high cardiovascular disease, high diabetes, HIV, AIDS, hepatitis C, and I could go on. All the things are concentrated. I know Dr. Wen is supposed to be on this panel, she's not here, but she can tell you of the study that was done that looked at those neighborhoods, the zip codes, and as Kellogg Foundation said, it wasn't the genetic code that gets you, many times the zip code. And so if you begin to look and see what's happening in those areas, it is, it's almost frightening to see the conditions that exist. So in those four groups that I told you about, we try to get community people and health professionals to come together to chair each one of those and work closely. And I know Dr. Prim, they're looking at grants and how to come up with different ways to address many of these issues. I'd say like all of social determinants of health, violence interacts with others that cause horrendous healthcare outcomes. Behavioral health bill, I have a behavioral health piece of legislation that I've just put in. That bill, again, is collecting data in the schools to look at the school, look at the behavioral problems that the kids have and how we can track those behaviors so that we can understand the violence and how violence impact those children. It has been known for a long time that it is linked, the violence is linked to all of these issues. The children who experience violence, according to the study, Harvard study, is that it shrinks, the cortex of the brain shrinks. And so they don't have the same kind of tolerance when they get in that classroom to listen and to learn. So this is where the behavior problems start, the fights with the teachers, they get expelled, and you can see the vicious cycle, how they end up in the juvenile justice system and in our correctional system. And many, before they get to the correctional system, are either killed or end up in a hospital where Dr. Cooper has to deal with the gun violence. Those are real. And other obvious areas of conversation about violence and healthcare policies and looking at the number, just a sheer number of admissions related to violence in a hospital. The costs. In Baltimore, the number of murders routinely over 300 each year. Keeping it below 300 has been a task. 344 murders this last year. Domestic violence, over 10,000 nationwide have been killed. And so I can tell you in our numbers, every year in January, we have a gathering at the General Assembly. And and families come, they cut out the hearts, and they write the names of their family member. And we stand in a circle, and they call out the name and tell. And this year, we had between 714 and 615. So we have to get the data from the year before. There were 25 women that were murdered, 2 children, 7. These are just relating to domestic violence now. This is not drugs and other things, just domestic violence. Of course, that may be involved in it. 2 children, 7 men in Maryland died as a result of domestic violence. 6 men committed suicide after actual or attempted murder. 1 man was killed by police, and the other man was killed by his girlfriend in self-defense. This is just a sample. The overall, nationally, it costs us, domestic violence costs the economy $5.8 billion each year. 4.1 billion in direct healthcare costs. 4.1 billion in direct healthcare costs. Over 900 million in lost productivity and 900 million in lifetime earnings. That says much, that what Dr. Cooper was talking about, the hospitals need to get involved. We need to look at the payers. We need to find out how they can get involved in reducing the number of violence that comes in. One of the other bills that I have is health in all policy. And you ask, what is health in all policy has to do? But if it's a correctional system, in this piece of legislation that I have put forth, Senate Bill 304, who else did I think Dr. Benjamin is one of his babies as well, on health in all policies. And so, of course, he sent a testimony in to help support my piece of legislation. And it was, the legislation has not come out yet because this department said, we don't have any money to staff the task force. Okay, so sometimes you have to be creative. And my creativeness is that I went to the University of Maryland, College Park, they have a Center for Health Policy and Health Equity. And I asked Dr. Stephen Thomas, do you think the university could take on the challenge of staffing that committee so that we can, task force, so we can move forward? He said yes. So last night, I think at about 2 o'clock this morning when I woke up, I read his letter that he sent back. So I will be presenting his letter to that committee to get the bill out, and the bill will come out. But I want to tell you, you have to be creative. Even my bill created the Office of Minority Health and Health Disparities in the state. The only reason they told me they didn't have any money either at that time. But what I was able to do is go to different and got in-kind contribution. And once it was started, the director had money from a cigarette restitution fund that we had won and was able to move it forward. So sometimes you have to think outside of the box. If you wait, you never get it passed. Last year, I had one on uterine fibroids in black women and why we have so much uterine women, and we have no money. Sickle cell, we have no money. So I got real creative. Sickle cell, I went to Care First Blue Cross and said, can you help us? Can you put some money in outreach? And then beyond that, I asked the University of Maryland, the dean of the School of Medicine, the other campus, could you study? Could you take on the job of studying? He said yes. So that is moving forward. So sometimes if you wait for the legislature to say we have the money, and anything they want to ask me when I presented my sickle cell bill last week, they said, well, why is it, you don't have the infusion centers and the things that you need? Well, I said, bottom line, racism exists. When you start hearing us talking about black people, diseases, nobody wants to put anything out. When I started speaking on racial and ethnic disparities in the legislature, I was very much invisible. Nobody wanted to hear it. But as I started putting forth the number of disparities, the mortality and the morbidity rate of our people, and I continuously put it forward and forward, cultural competency and literacy, and eventually it takes on. It doesn't happen overnight. You have to keep repeating it. You have to put it there. So just quickly, I don't know how much more time I have to speak. The policies that in every government agency that will come on the health and all policies, we'll have the correctional facilities and all of that. Environment in the prison. Okay, good. I have, there's many, many issues. I have one on, which will also speak to violence in the correction. It's Senate Bill 869, and it's the Commission on Reconciliation and Equity. That is a conversation on race. They never had that before. They're going to have it this year. They're going to have it on March 9th, next week, this coming Wednesday. We're going to talk about what's happening and how it impacts negatively on our people. And so I'm excited about some of the things that are happening. There are numerous pieces of legislation. My time will not be able to tell you. There's a whole page of legislation on criminal justice issue. One on criminal law, committing violence in the presence of a child 2 years and older. That is going to increase the penalties. Law, use of possession of control, dangerous substance, and how those violence comes. Another bill on criminal for the gangs, and of course increase on those with loaded handguns regulation who violated those laws. Number of bills on human trafficking, and again on the violence that comes. But quickly, as I have my few more seconds here, there's one, an inmate writes to me, my staff says that my name is written in the bathroom of all the prisons, because they do write. And yes, and so one gentleman had been writing to me since he was 91. He was 91, he was in a wheelchair, he had arthritis real bad. He couldn't move from point A to point B. He had to go to the bathroom, and anything he needed help, he was in pain. Nothing they were giving him was helping. I had to intervene to make sure they gave him the right pain medication and begin to take care of him. I put a letter in to try to get some compassionate release in the legislation last year. It failed. This year I put the similar legislation back in. However, I got a letter from another inmate last week informing me that particular inmate is serving his 45th year in prison. He was sentenced when he was a teenager, okay? And so we're working on that issue as well. But he then sent me in his letter that the man that I had been advocating for died. He was 93 years old. He died last week. That really hurt me. I really felt it, because I figure all of us would like to die with some form of dignity and the conditions to which exist. So violence got him there. Okay, no doubt. If you served that time, you murdered somebody. Because they will say to me, well, why is he in there? It's obvious. Okay, but our responsibility as legislators and as a state is to take care of the folks that are in our care. We have a responsibility. And so with that, I will close and I will take any questions.
All right, before we take our break, I think we have a minute or two, correct, Dr. Mitchell, to take some questions. Oh, no, thank you. I want to thank Senator Nathan-Pulliam.
Their points to take home. I failed to give you points to take home. Can I do that real quick?
Yes, ma'am.
While you're doing that, my points to take home for each and every one of you is make sure you know who your legislators are. Okay? Not only do you need to know who they are, make an appointment once you know who they are. Come and talk to them in person. Send them an email if you have to on an issue. And if you're going to write them a letter, don't write them 10 pages. Just write 1 page and get to the point of what you want to get and what your outcomes. Okay? If not, they're not going to read it because we get so many letters. Okay? Any one of you can have legislation introduced. But before you do that, your legislator is going to listen to you if you're involved in their campaign, involved in the things that they do. They will listen to you much quicker. And make sure that you are in fact registered to vote as well. Because many times I am so tired of going into rooms and ask doctors and nurses, what district do you live in, who represents you? They haven't got a clue. And if they don't have a clue, how the heck you're going to be able to effect some change? Okay? And some will say, well, I can't be bothered with politics. Just keep in mind that the quality of the very air you breathe and the water you drink is politics. And thank you.
All right, this represents a perfect marriage between the medical profession and the legislative process in an effort that we can end up with policies, health policies that impact us in a positive way and help reduce the cost of providing medicine to those who are victims of violence. I think we have a few questions. Had the lady here in front and then the back, the gentleman.
He's got the microphone.
All right, microphone?
Yeah, we'll bring it to her.
Can I just take it since I got the mic? And I'll walk up to her.
Certainly.
Yeah, I'm Morris Brown, Chair of Family Medicine. Dr. Cooper, could you share with us that code? Because a lot of us have similar programs. I have one in Dayton, Ohio, where we are trying to intervene in the hospital. It's not as good as your program, of course. But is that code, if it has been approved, can you share that with us?
It hasn't approved. It starts in July, so it hasn't been. We published by the Uniform Claims Committee as of July. So it'll be in the report. So I have the exact number, but it does come out in July. We just learned that we were approved in January.
Okay,
That was approved. The challenge, of course, is going to be, now we have the codes approved,
Right.
but now we have to get the third-party payers to say that we will pay for it. And I'm going to be talking to people like Dr. Benjamin to say,
But the more of us using it would help them to do it. Yeah.
All right, one more question.
Okay. Hi, Virginia Kane. I'm a founding member of the Indiana Health Information Exchange, and I want to compliment you for all the work you've done for the Information Exchange in Maryland, by the way. Question to you is, how do we best support you? So when they're having legislative sessions or whatever, is it important for us to be there to testify? Does that make a difference?
It makes a whole lot of difference. Okay, I always tell a story about the ferret. We had a bill on ferret. You know what ferret is? Like a little rat. Okay, and these children wanted to make sure that their ferret was quarantined instead of being put to sleep if they bit someone, just like we do dogs. They came in numbers, in busloads. Every space in the committee hearing room was full. They watched every vote. They testified. And when I discovered that Ferret Club was in my district, I was the first one to vote. Okay? And they got their bill. They watched, they followed everything, and it came in numbers. If we, as a community, when we talk about gun violence, when we're talking about the issues on healthcare that is important to us, if we came out in the numbers that we should, it would make a difference, tremendous difference. We'd be able to get our bills passed. Not only did they stay in there and watch us, they even got to the balcony. When the bill got to the floor of the Senate and the floor of the House, they were up in the balcony holding up pictures of the ferret, holding up everything. And they got their bills passed. It's what we have to do. I tell you the story because it is important that we're there. And when I do the one on this coming Wednesday on reconciliation and equity, to start the conversation on race, yes, I want everybody, as many people who can come, at 1 o'clock in the EHE committee in the Senate to come and either sign up to testify or just call my office at 410-841-3612, 841-3612, and say I want to come. I will make sure you're there.
Thank you very much, our panelists, and here is Dr. Mitchell.
Okay.
Let's give our panelists another round of applause. This has been great.